Hi, my name's Avery, and I'm here with Bridget and Torian, and our presentation is over multiple sclerosis. A little introduction to the diagnosis. MS is a chronic immunological and neurodegenerative disease where the immune system attacks the myelin sheaths of the CNS. The diagnosis combines clinical, imaging, and laboratory evidence. Clinical symptoms involve 2 or more relapses of clinical symptoms and evidence of 2 or more objective lesions. MRI findings is a dissemination of lesions in space and time. And there's also a CSF analysis, which is presence of oleochondral bands. Some common physical changes that you may see are motor impairments, which can be muscle weakness, spasticity, ataxia, dysarthria. Sensory disturbances, and that it could be abnormal sensation, tingling or prickling sensation, and then also pain and temperature sensation distortion. And then there's also some visual deficits that can involve double vision, unilateral optic neuritis, and ocular pain as well. Some cognitive changes that you can see are short-term memory loss, attention deficits, processing speed reduction, visuospatial abilities impairment, and also verbal fluency reduction and executive functions impairment as well. Some emotional changes that you'll see are depression, euphoria, and emotional lability, and that's just like mood swings caused by the frontal lobe lesions. So overall, this diagnosis, MS symptoms can vary greatly among individuals, and early diagnosis and treatment can help manage individual symptoms and improve their quality of life.
So one of the assessments of MS is called the Assessment of Motor and Process Skills, or AMPS, and it's to assess the quality of ADL performance. The AMPS examines interplay between the person, the ADL task, and the environment. There are a total of 36 items that are measured. It rates the effort, efficiency, safety, and independence of each of those items. They rate each of those from 1 being no problem at all to 6 being incoordinate or not testable. Some examples of the ADLs measured include folding a basket of laundry, eating a meal, putting on socks and shoes, sweeping the floor, setting the table, feeding a pet, and much more. The person who administers it does have to have a certification. And the Shirley Ryan Ability Lab have normative data for many of the diagnoses. So for the MS normative data, it includes 44 participants, and in the motor items, the mean was 2.2, while the ADL process skill was 1.37. And the rationale for choosing this assessment is it is specific to ADLs and is a standardized test that has much reliability. Another assessment is called the Functional Assessment of Multiple Sclerosis, or FAMS, and is specific to gaining information about the clients with MS quality of life. There are 59 items that the patient reports on, with 0 being not at all to 4 meaning very much. There are 44 of those items that pertain to 6 quality of life domains, which are mobility, symptoms, emotional well-being, general contentment, thinking/fatigue, and family/social well-being. The total score ranges from 0 to 176, and higher scores indicate better quality of life. The normative data included 377 people with MS, and the total FAMS mean score was 107.5. And then there was a clinical cohort with a total mean score of 110. The reason this assessment is appropriate is because it is specific to MS and the client's quality of life.
The Multiple Sclerosis Functional Composite, or MSFC, is a standardized assessment used to evaluate neurological functioning in individuals with multiple sclerosis. It includes 3 components: the timed 25-foot walk to measure walking speed, the 9-hole peg test for manual dexterity, and the paced auditory serial addition test for cognitive function. The MSFC takes about 30 to 45 minutes to administer, is primarily for adults, and costs vary based on training and materials. This comprehensive tool provides reliable and valid data widely used in clinical trials and research, making it essential for tracking disease progression and evaluating treatment effectiveness. Now we're going to discuss some interventions. One intervention that occupational therapists can do with those with MS is education on fatigue management strategies. This could include doing things sitting down, taking rest breaks, and activity adaptation in order to expend less energy while completing daily tasks. This will allow clients to better manage symptoms of fatigue that could interfere with occupational participation. Another intervention could be to recommend and/or practice with adaptive equipment. AEs such as weighted wristbands, splinting, tub benches, and grab bars can help immensely to manage attention tremor and improve limb use. Cognitive rehabilitation is also a great intervention for those with MS. External and internal memory aids, attention training, and use of the functional environment in therapy sessions can help to manage cognitive symptoms that accompany MS and better allow clients to remain as independent as possible. And these are our references.